Digital acceleration is here. Health systems are walking the path, but are they in the right direction? Welcome to Patient Journey Pioneers, roadmaps from the top digital leaders in healthcare, who share insights and strategies that are pushing the patient journey to new heights. This podcast is brought to you by Hyro, and I'm your host, Liat Kozuch. And today we have a very special guest, Jake Dorst, Chief Information and Innovation Officer at Tahoe Forest Health System. Jake, it's great to have you here.
It's great to be here. Thank you for having me.
Thank you. You know, we shared some fun times at the recent Becker's annual meeting in Chicago. We ate at the best sushi restaurant in town with our folks at Kairos, so we have some shared memories there. So Jake, thanks for taking your time. Let's jump right into it. What is it that you're working on today when it comes to the digital patient experience?
You name it. So everybody kind of went into hibernation there during COVID, so now everybody's coming out of hibernation. So we've got massive projects. So we moved to Epic. So I was able to get us onto a Community Connect platform, moving off of Evident, which is the old CPSI, and several, 6 other EHRs into a unified, integrated Epic environment. So we did that 7 years ago. And we've been building on that, what we've called the digital front door forever. We've been building on that since that time. So we've, my chart, and we created a centralized access center for scheduling, helping our patients try to find the open slot. So access to care is kind of on top of our priority list right now. So that's one of the reasons I'm talking to Hyro and Kairos and looking at, is there a way for me to simplify my user experience, my patient experience on, one, finding the right care and the right time and the right, not 6 months out, those types of things. What doctors are actually seeing new patients, who has open panels, those types of things. We're still good, but we could be better as far as our opening up our schedules and getting people in faster. Companies out there like LeanToss and other companies that are using AI to really to look at your data in a mathematical way and look at your scheduling and find out, are you utilizing these slots to the best of your ability, and really, making it as efficient as you can using lean methodology.
What is your process usually for defining KPIs when you're trying to guarantee a successful outcome from all these digital transformation projects? And if you can, maybe use an example to explain from the past year.
Sure. So we do a lot of patient surveys, through Press-Ganey and, our own survey tools. We survey our employees a lot. We get a lot of surveys every year. So I think that's kind of our main tool, is how, when we're talking about satisfaction, and that's what we're looking to aim, right now with increasing slots and access to care. We want to be able to see, we can look at the data, like, is this physician or this provider, clinician, are they working at the top of their schedule, right? Are we missing opportunities for cancellations and filling them with people that want them, want those slots. So those are all performance-based metrics, which we have now. And those are the types of things we're going to be looking for in the future. Like if we put something like your product in Kairos in, can I poll them? And I'm sure there's tools in your software to poll them after their experience, like how was rate your experience, or give us some feedback, those types of KPIs. So we do that now with a lot of our programs, and we will probably do the same with going forward with whatever we end up with doing for intelligent chatbots and intelligent scheduling, etc.
As a CIO, what do you expect as far as any pushback? How would it impact clinical and operational leaders when you're pushing these projects through?
Sure. Yes. So just taking So traditionally, doctors' offices or providers' offices, clinics, etc., were owned independently, right? So that's kind of shifted over the last several years into, and California just allowed critical access hospitals to hire providers directly, whereas we used to have to contract with them as independent contractors. So now they actually work for the organization. And now we're, like before they had a complete autonomy over their schedules, right? So that's always an issue, regardless of what you're doing. And has always been an issue is when you take over a practice that was previously run, the CEO with somebody in there, right? Usually the physician, the elder physician. There can be pushback. They had autonomy on their scheduling. Now you're shining a light on that and saying, hey, well, I like to go swimming or paddleboarding or whatever on Tuesdays. There's a lot of recreational out there, and it's a big reason why people live here. So you have to find that balance of, okay, well, you're living here for a reason. It's expensive to live here, so you don't want to spend all your time in the office like I do. But you want to find, okay, well, that's fine. You can still go on Tuesdays, but the Thursdays we got to have you. You got to work clinic, right? So those types of conversations are never easy. Luckily, I don't really have to have those conversations. But I have a good admin team. My other but my other the other members of my admin team are on board with this notion that we should really try to increase our efficiencies as much as possible and get our patients in sooner. Get them. We have very good care. We have high quality, mostly 4 or 5 star care that we've been known for. Right. We have once you get into the system, it's a very pleasant experience. It's just getting into the system. So that's another KPI that we can track, that we've tracked in the past, is what's called out migration. So you can find there's companies now that sell data from the private payers like Blue Cross, Anthem, etc. And then I can say, show me everybody with a billing or home address of 961XX, which is this area, that are getting services at 85 whatever, which is Nevada. And then I can really kind of start to see what services are they getting. Are those services I should be providing? Or is that a service I provide that they're choosing to go elsewhere? And if that's the case, that they're choosing to go elsewhere, why is that? Is that because we told them it was going to be a 3-month wait before they got in? Probably. I mean, I would, right? You tell me it's going to be September before I can see anybody, I'm going to go to Reno. Or SAC, or somewhere else. So there's definitely, by SAC I mean Sacramento, I'm sorry, using colloquialisms. So those are things that we can also measure, but yeah, pushback, right? So you're taking away layers of autonomy that they've never had to do before. And there's been a lot of change, I feel, for the providers, because it's not how it used to be. Yes, the data, it's really become a very intensity. Like there's all kinds of work to be done that there wasn't in the past. Well, it wasn't put on the provider. It was done, but it wasn't done by the providers for the most part. It was like a lot of the paperwork and charting and all the things they have to do now. And then really kind of looking at it from, I don't want to say corporate medicine, but I worked in corporate medicine, and that's how they looked at it, as like slots are money. And if you're not filling those slots, then you're losing money. And they were beholden to shareholders, right? So we're not necessarily beholden to shareholders, but we would note with the old famous saying of no margin, no mission. So we got to make enough money to keep the lights on and allow people to afford the lifestyle that they have in this. It's a resort town.
Are there other challenges that healthcare executives in charge of patient journeys face that isn't being talked about enough, in your opinion?
I think they're talking about it enough, but I think, well, we are anyway. Just the lack of the hiring process. Finding primary care physicians is pulling a rabbit out of a hat nowadays, and especially up here when the housing market here is insanely expensive. We have the benefit of being close to the Bay Area, And we also have the drawbacks of that is a lot of the houses up here are second homes, and people are making all cash offers 10-15% above asking, which is good for my property value, but it's not good for, if I need a PC tech that's making 20-25 an hour, they can't afford to live here, right? So the city and the hospitals, we're considered a hospital district, so we're actually part of the government. So we're working we created a joint powers authority with some other districts in town, like the Power, and people that also they're good paying jobs anywhere else, but here they're kind of mediocre. So we're trying to find, is there a way that we can build housing or lease housing or find a way to lower the barrier of entry into this area?
Well, we'll go from challenges to a little game. It's time to play a game where you place your digital bets, Jake. So I'm going to be naming an emerging technology in healthcare, and then you tell me if it's bullish, meaning believe it's here to stay, or bearish, meaning less belief. Are you ready?
Yeah.
Number 1, telehealth.
Here to stay, bullish. I think telemedicine's been here. I don't think it's gone anywhere. I think that with the pandemic, when the government lifted a lot of the barriers to using that, it shot like crazy, like Zoom and all those Amwell, Telemed, all those companies really made out because all of a sudden I turned on Zoom and I was doing telemedicine that same day. So it really shows if the government can get out of the way of certain things and work on the reimbursement, like the old school CIO'S, which I agree with, is if I can get just arbitrary number, if I get $200 for a patient visit, but I only get $100 for an in-person patient visit, but I only get $100 for a telemedicine visit, is it worth it to me to invest the marketing, convincing my physicians to work half a day or a day only doing telemedicine? There's physicians that probably don't want to do telemedicine just because it's not their, they don't like it. It's not for every provider. And
right.
But I think the government and everybody else saw when they got out of the way how quickly innovation happened with just about every hospital.
Wearables.
I mean, again, I don't know if it's emerging. We were doing wearables 8 years ago with homegrown software from another luxury we have. We have a lot of young, retired programming geniuses that live in my neighborhood who have all startups. So I met a guy that had a startup. We worked with getting, at the time, it was Misfit and Fitbit and Garmin, just the steps tracking. And his idea was, he's still in business. It's called onebios.co, not com.co. And he does a lot of the tracking for large university systems and hospitals now for glucose. So diabetics, pre-diabetics, and helping people control that better. The idea behind it is a lot of organizations self-insured, right? So if you can't manage your own self-insured population, which I have all of my insurance claims, I have 10 years of health data that we've been, like screening data that we've been doing, because we incentivize it, and the government allows for those incentivizations. So we were able to really bring all that together. However, I mean, I think there's limit, like everybody in the world doesn't need to go home with a wearable, right? Like you're going to have data overload, like blood pressure cuffs. The Withings products all have open APIs where you can integrate with scales, even spirometers, glucometers, you name it, like you can integrate with it. And blood pressure cuffs are the big one that everybody wants now, but I'm like, who's going to monitor it? Like, it's really, you have to put the program together. One of the good advice I've gotten in the past was, I always ask people now, it's like, what's your business case? What's the business problem you're trying to solve? And if it's not a business problem, is it a patient satisfaction or care or safety? Which is really top of the list. So you ideally you'll have both. You're solving a patient satisfaction or a patient safety issue that also is going to cost you less money, or have a return on the investment. So I would say bullish, not because I think it's necessarily the best thing in the world, but I think people think it is, if that makes sense.
You're being very
I think
kind
they're going to
today.
do it. Yeah. I think people are going to do it just because I've had people come and ask me. I said, we tried this 8 years ago and you didn't like it. What's the difference now? But,
Right.
and you can now push back with Epic and Cerner and the others. They have these open APIs now with the, HL7 and FHIR standards. And you can push data back into your EHR, which is handy.
Mm-hmm.
But again, who am I going to ask? Like, okay, doc, now Jake's got high blood pressure. We want you to monitor his 50 home readings every month. He's going to be like, what? No. Or she's going to be like, no, I don't want to do all that.
Right.
And that'll get
right.
pushed down to an MA, but I don't know. But what's the benefit of that, right? All they really need to know is what's the macro. Is it going up steady or is it going down?
Okay. Moving on to the next. Conversational AI.
Bullish. I think the whole world's moving to that. So, and I like what you guys are doing with contextual kind of thing. So, we've all experienced good ones and we've all experienced bad ones. More bad than good, probably. But I mean, I forget who it was on. I was on like the chat bot. Some software I was using, and I went to their support page, and they were like, "Would you like to try our chat support?" And I was like, "All right, I'll try it." And it, like, within 4 or 5 interactions, I had the problem solved, which would have, if I had to pick up the phone and call somebody, or like, "What's your name? What's your account number?" Like, all that stuff was already in there, so it was simple.
Right.
So I'm very bullish.
Like that autofill type of thing. Yeah.
Yeah. Everything was there. They knew who I was. They knew what version of the software I had a license for, and I was asking. You have to know how to. I mean, maybe it's different because I've been doing this for 20 plus years, but you have to kind of know you're talking to a bot, and you have to know how to. Sometimes you have to know how to really sculpt your question to help the bot not get confused with extemporaneous words like extemporaneous.
Remote patient monitoring.
Again, I think it's a niche, however you want to call that, but it's only, I think that's useful. We've worked on, one of the cool things we had here was the Tahoe Forest Institute for new tech research, things like that, rural health. And we went out, instead of trying to create software and then find a problem, we were trying to find a problem and create a solution for it. One of the things is white blood portable CBC machine, basically, because we have a large cancer center, which is a great cancer center, by the way. If you want to get treated in one of the prettiest places on earth, so we were having folks come in for chemotherapy or whatever, and they would get here. We'd take their blood and run the test, a complete blood count. Their white cell blood count was too low, or their whatever it was. The metric wasn't allowing them to get, so they drove an hour or whatever. So one of the oncologists, Dr. Larry Heifetz, was like, we need to come up with a way to send a CBC machine home with somebody, which if you've ever seen a Coulter counter, it's the size of a table, right? They've gotten smaller, but they're hard to calibrate. They're super expensive. So the old way, and that runs blood cells through an aperture, and every time it clicks through the aperture, it counts it, right? The old way of doing it, you had a human look through a microscope and they would physically count the blood cells. With the advances in smart software and video capture technology, they were able to create a machine that basically, and there's one in Israeli company that's doing this as well, but they created a machine that could, the trick was getting the layer down to one cell. Like, so you take a pin, it was kind of like Elizabeth Smart's company where, it's just one little drop of blood and it takes it and it gets it down to one layer and then takes this image of it. And then the software counts through it and gives you back and before they have to leave the house. So they can say, hey, I'm coming in. I got my appointment reminder. Hero sent me the text or whatever. And now or Hiro sent me the text. And now I'm going to say, yes, I did. And here's my count. Right. And as long as it's good, they can come in. but that saves them a trip. So that was some of the Tahoe Institute for Rural Health Research, the TIRHR is what it was. So we were doing all kinds of stuff around that. Wearable heart for using radar, which was crazy. It's like a low dose radar that shoots radar into your heart that detects AFib and a bunch of other stuff. Cardiac motion is what that's called. We were some cool projects, but I think yes, home. I'm bullish again because I think there's big companies behind that think they can make a bunch of money on it, which they will. But it's really. I don't think everybody has to go home with a blood pressure machine. I don't think everybody has to go home with a glucose. If you don't have these diseases, you don't need to know. You don't need to track those. But if you're a cancer patient and there's a tool out there that can, prevent you from wasting 2 hours in a car when you're sick and on chemo and everything else, I think that's a good thing for sure.
What are some insights as a CIO today that you've gathered from other industries that can be applied to improve patient experiences?
So Maryland was interesting. They have what's called the Medicare waiver. So they have, basically the state sets the rates and collections and all that stuff. So they offered a program called TPR, Total Patient Revenue. Look it up if you're interested. And it's basically capitated funding. So they went into these hospitals and they were like, we will offer you this. And based on your numbers from last year, you made $400 or $500 million, right? So we will guarantee you that money. You're going to get paid that regardless, but you have to keep your quality up. And it was a pilot program, which is now I think permanent for some if you choose to get in it. But what that did for us, which was amazing, is that once you change the way that like the money's guaranteed to come in, so it's kind of like a European model where it's capitated, but it's guaranteed, right? So we went into this hyper lean mindset. Like any dollar we saved was a dollar we put in the bank, right? So we started doing all kinds of lean, it's called Kaizen events and trainings and looking at like Gemba walks and trying to figure out how can we cut out waste and efficiencies while keeping our quality at a certain level, high level. Because we were going to, the words of my old CEO from there is like, we're going to compete on quality and we're going to win. And because that's what you were competing for there, because it was mostly cap. I think there was 9 or 10 hospitals that joined that program in the state, which they were in a unique position to do that because they controlled all the money. I think that may be the wave of the future. But in that town, there was the old Mack truck factory that was bought by Volvo, and they were a very lean driven organization. So we went and did field trips with them really to understand what a Gemba translate. I think it's like a shop floor, right? So going to the shop floor. So you would sit down you'd bring everybody in the room that had ownership in that, what's called the value stream. And then you'd map it out. First you go to the floor and watch and observe and look for obvious things. And then you map out the value stream. And then you put the pinch points in there, and then you try to solve for those pinch points. And we shaved off, a couple of like 70, 80 minutes out of the discharge process, which there, like the healing started there, but the finished healing was going to be at your house or wherever you were going. So the idea was like, let's get folks out of these beds so they can go home and nobody like stay in the hospital too long anyway. So right. That was a big deal for us, is really understanding that lean. And then we're starting to do that here. But I think if the government moves, like California has talked about a single payer system, if those types of things really, everything's driven by the reimbursement model. Like we saw with telemedicine. Once that was turned loose, everybody did it. Everybody. For various reasons, like you didn't want the doctors there getting COVID, right? Or the providers dealing with COVID patients, or vice versa. The patient that doesn't have COVID coming in and getting COVID from someone that has COVID. So that was a big, like we had to do it and everybody did it. So I think if you see that, if you see like a single payer model get traction ever, I don't know if it will or not. I'm kind of I'm kind of bearish on that.
What advice would you give to a CIO just joining this ecosystem in 2022 and then 2023 and onwards?
I learned a lot, like I said, through the unique position I was in at CHS, Community Health System. So I traveled around a lot. My advice to people just becoming CIOs or even IT directors is go into the hospital, round, meet the providers, meet the nurses, meet the dietitians, the EVS, everybody that plays a part, radiology, pharmacy, laboratory. Go let them know who you are and ask them, what can I do to help you? Is there tools you need, or is there something that can help improve your job that you know about that you haven't told anybody, kind of thing. That's a big part of it, is really having that level of confidence and familiarity with your processes. Like, that's another thing, is really understanding how a hospital operates, from how a patient finds the service they want to getting that service, to how that ancillary, if they get labs, which they almost always do, labs or images or drugs, through the pharmacy, however, understanding how all of that works, and then the bill and how billing works, because you got to get those bills out the door, paid, approved, and brought back in. And I was doing a lot of I think Chime is a good one. They're working on becoming more open, I think, to a lot of the issues is all the folks there, the CIOs and things, they've known each other forever. So it's a bit cliquish when you first join. I have a bit of an outgoing personality, so I don't mind walking up to a stranger and introducing myself. There's another one called Vive now, and there's Becker's, where we met. I think Becker's I've been going to Becker's ever since they started it, and I like it. There's Hims, but Hims is a monster. You get lost in the sauce out there. With Becker's, and Becker's is getting bigger and bigger, but when I went, the first one I went to, I think there was like 800 people or something. I think there's like 6 or 7,000 now. The vendors there are strong. The education is put on by people that are actually doing the work, which is nice. It's not sales folks for the most part. Not that I have anything against sales folks, but there's people that I want to talk to that have actually implemented it. And I always have those types of questions.
And what are you reading nowadays? Where do you get most of your information? How do you stay up to date?
I mean, I have so many lists. Like, I have a news aggregator from Tom's Hardware has actually been doing some cool stuff recently. They've kind of moved out of that niche world of hardware, high-end hardware, to really just a lot of things. But Becker's has great, they're like a news aggregator themselves. And they give you kind of the watered down version of, not watered down, but synopsized, I guess, like through the OpenAI software we had looked at, which is cool. Like, security is a big thing. Like, that's the thing I have every day. I check. I have a feed coming in of anything from ISAC or any new threats. Palo Alto is who we use basically for our firewall. So I try to keep up on any kind of patches or anything that my guys may have missed. They probably get sick of my FYIs. Yeah, no, but it's good because they're like, oh yeah, we know about this. We got it patched, because of the patching. Staying on top of patching is a big part of any IT position. Constellation Research, if anybody follows them, they're also very good. Ray Wong and his crew put on good events, and I always come away from, they're in all kinds of other industries, and I come away from those events really inspired, like, oh, this is what real world folks are doing. Because, IT and healthcare is a bit stymied from the years of neglect, I guess. So it's good to see how other organizations are really leveraging AI and chatbots and smart automations. Those things are really good. So Constellation Research, look them up.
To end this off, Jake, I want to know who you view as a trailblazer in the healthcare IT industry that you'd perhaps like to nominate as a future guest on our podcast.
There's a lot. Aaron Meary comes to mind immediately. He's out at Baptist, recently moved to Baptist. He's CIO out there. His energy level is amazing, and he's brilliant. And he's also got a seat at the table with the federal government on a lot of the goings on of decision making at that level. So I'm sure he would bring a unique perspective to these types of questions. Dr. Zafar Chowdhury, he is over at Seattle Children's, super smart. I always look to him he's a super honest person too, which I like. He's like, he'll be sitting in the middle of a vendor thinking, I said, what do you think? You going to put this in? He's like, I sat through 3 of these presentations, and the more I hear about it, the more I don't think I want it.
Well, we need that honesty on this show.
He is honest and brilliant. Again, who else? Oh, Chuck Podesta, super nice guy. He's been a CIO for a long time. Very smart, seasoned. I lean on him a lot for questions. Luckily, he used to be this UC. He's been in Boston. He's a Boston guy, but he was at UC Irvine for a while. And now I'm lucky enough that he took the open CIO job at Renown in Reno.
Thank you, Jake, so much for joining us and sharing your unique perspective.
My pleasure. Thanks for having me.
Thank you for listening to Patient Journey Pioneers, brought to you by Hyro. Subscribe to our podcast on your favorite listening platform. See you on our next episode.